Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Today, we will explore the critical area of occupational exposures from the perspective of emergency medicine and toxicology. This is a vital topic, as recognizing these exposures is paramount for appropriate patient management and preventing further cases in the workplace. The management of occupational exposures requires preparedness from local emergency response providers, including hazardous materials hazmat teams. Healthcare providers across various disciplines, including ambulance personnel, nurses, physicians, and hospital officials, should actively participate in emergency response planning and drills with local hazmat teams, highlighting the intersection of emergency response and occupational toxicology. Furthermore, a crucial principle is that healthcare facilities must be prepared to manage patients who are contaminated, as many victims of chemical exposures may present directly to hospitals without prior field decontamination. Decontamination is essential at healthcare facilities to prevent further absorption by the victim, prevent secondary contamination of other persons or equipment, and prevent the closure of the facility. Understanding these occupational hazards and the principles of evaluation and management is crucial for healthcare providers responding to both acute chemical incidents and the more common, yet subtle, presentations of work-related illnesses. Here are 10 learning objectives derived from the provided sources on occupational exposure. First, it is crucial to recognize the importance of occupational exposures in emergency medicine and toxicology. These exposures significantly impact appropriate patient management and the prevention of further incidents. Second, healthcare providers have specific roles and responsibilities in emergency response planning and drills, particularly when collaborating with local hazardous materials teams. Third, it is essential to identify fundamental safety principles for first responders. Additionally, there are valuable resources available for obtaining information about hazardous substances during incidents. Fourth, one must assess the potential for secondary contamination of personnel and facilities, along with describing primary methods to reduce this risk. Fifth, obtaining a thorough occupational history is necessary to identify potential work-related chemical exposures in clinical practice. Sixth, it is important to explain key principles in the evaluation of a potentially poisoned worker. This includes understanding predominant exposure pathways and the concept of the index case. Seventh, one should summarize relevant regulatory requirements from organizations such as the Joint Commission and the Occupational Safety and Health Administration. These requirements pertain to hospital preparedness for decontamination and the training of involved personnel. Eighth, it is important to recognize and differentiate between common occupational toxicities and their effects on organ systems. Examples include acute irritant inhalation injury, asphyxiation, inhalational fevers, and various organ-specific toxicities. Ninth, outlining the rationale and key steps for healthcare facility-based decontamination is crucial. This includes emphasizing the preparation required for managing contaminated patients who present directly to the hospital. Finally, developing a high index of suspicion for environmental or chemical exposure is vital. This is particularly relevant in cases involving toxic gas exposure or oxygen deficiency in patients who present with sudden collapse or cardiopulmonary arrest, especially in confined spaces. Let us explore the critical issue of occupational exposure from the perspective of emergency medicine and toxicology. This topic is vital because recognizing these exposures is essential for appropriate patient management and for preventing further incidents in the workplace. Many local emergency response providers, such as those on hazardous materials teams, receive training to handle victims contaminated by chemical substances. This highlights the intersection of emergency response and occupational toxicology. Therefore, healthcare providers across various disciplines, including ambulance personnel, nurses, physicians, and hospital officials, should actively engage in emergency response planning and drills with local hazardous materials teams. Accidental releases of hazardous materials and the potential criminal use of chemical weapons pose constant threats, necessitating preparedness from local emergency response providers. Hazardous materials teams typically consist of fire, environmental, and paramedical personnel. They are trained to identify hazardous situations and lead a rapid response. Within a hazardous materials team, a medical officer is often designated to oversee health and safety. This individual, supported by a technical reference specialist, bears the responsibility of determining the nature of the chemicals involved and assessing the likely severity of health effects. They also decide on the need for specialized personal protective equipment, the required type and degree of decontamination, and supervise triage and pre-hospital care. The medical officer collaborates with the site safety officer to ensure the safety of response workers and to monitor entry and exit from the spill site. This may involve contacting receiving hospitals to discuss the care needs of victims. Recognizing potentially hazardous situations and taking steps to self-protect from injury are fundamental skills for first responders. It is crucial to obtain accurate information about the identity and toxicity of each chemical substance involved. Situations involving substances with poor warning properties or high vapor pressures warrant particular caution, especially in enclosed spaces. Substances that lack warning properties can cause serious injury without noticeable signs such as smell or eye irritation. Furthermore, high vapor pressures increase the likelihood of dangerous concentrations of air. Additionally, gases or vapors that are denser than air can accumulate in low-lying areas. The potential for secondary contamination of emergency response personnel, equipment, and nearby facilities is a significant consideration. The risk of secondary contamination can vary depending on the specific chemical involved, its concentration, and whether initial decontamination has been conducted. It is important to note that not all toxic substances pose a secondary contamination risk, even those that are highly hazardous to rescuers in the immediate hazardous area. Generally, exposures that occur solely through inhalation, without any external contamination, do not present a risk for secondary contamination. To effectively manage exposures, the essential steps include decontamination, removal from the exposure site, and oxygen administration. Furthermore, it is crucial to ensure that responders have the necessary personal protection equipment. Self-decontamination, such as using an emergency shower, can be performed immediately after an exposure incident. A notable example of this is a case in which a worker was splashed with clothing dye. Emergency medical response to a hazardous materials incident requires prior training and planning to protect the health of both response personnel and victims. The development of response plans and training must be flexible, as the hazard level and necessary actions can differ significantly based on the circumstances and types of chemicals involved. Valuable resources for identifying hazardous substances and obtaining critical information include the National Institute for Occupational Safety and Health Pocket Guide to Occupational Hazards, the Emergency Response Guidebook, and the Wireless Information System for Emergency Responders. Let us explore the principles of healthcare facility-based decontamination from the important perspective of occupational exposure, integrating insights from the provided texts. It is crucial for healthcare providers to understand these principles in order to ensure patient safety while also safeguarding the health and well-being of response personnel. Historically, the responsibility for decontaminating victims exposed to hazardous materials primarily fell to community-based hazardous materials response teams. However, recent events have highlighted the critical reality that many victims of chemical exposures, as well as potential biological or radiological incidents, will present directly to healthcare facilities without undergoing prior field decontamination. This shift means that hospitals can no longer assume they will not be the primary point of contact for a large number of contaminated victims. Events such as the Tokyo subway sarin attack in 1995, where healthcare workers fell ill from secondary exposure to victims, and an industrial chemical spill in Indiana in 2005, which resulted in symptomatic exposures to hospital staff due to vapors trapped in clothing, serve as stark reminders of the risks involved. Therefore, a fundamental principle is that healthcare facilities must be equipped to handle contaminated patients. This readiness is not just a clinical necessity for patient care. It's also a vital safety measure for hospital staff. Decontamination, removing or neutralizing hazardous agents, is crucial in a healthcare setting for several important reasons. It helps prevent or reduce the further absorption of the agent by the victim, thereby lowering subsequent toxicity. It mitigates the risk of secondary contamination of other individuals or equipment from the victim's clothing or skin, and it avoids the need to close sections of the facility, like the emergency department, which contaminated patients may access. From an occupational health and safety perspective, there are significant regulatory requirements that guide healthcare facilities and the personnel involved in the decontamination process. The Joint Commission and the Occupational Safety and Health Administration enforce these regulations to ensure that hospitals prioritize the protection of their workers. According to the Joint Commission, hospitals must implement an emergency management plan that outlines facilities designated for isolation and decontamination during incidents involving radioactive, biological, and chemical threats. The Occupational Safety and Health Administration provides detailed mandates regarding the necessary training for personnel involved in decontamination. Medical staff responsible for decontaminating victims are required to receive training at the first responder operations level. This training focuses on the proper use of personal protective equipment and appropriate decontamination procedures. Employers are obligated to certify that their personnel are trained to safely fulfill their responsibilities. This training involves a minimum of 8 hours of instruction or demonstrated proficiency, in addition to an annual refresher course. Furthermore, the Occupational Safety and Health Administration mandates employers to ensure a safe working environment, recognizing that victim decontamination is a crucial aspect of maintaining the health and safety of employees. This situation underscores a critical principle. Healthcare workers engaged in decontamination activities are working in environments that pose significant hazards. They require specialized training and protective measures to operate effectively as occupational responders. The potential risk of secondary contamination is a serious concern, necessitating the implementation of appropriate protective measures and adherence to established protocols. Medical monitoring for personnel who enter hazardous zones such as exclusion or decontamination areas is also required under the Occupational Safety and Health Administration standards for hazardous waste operations and emergency response, known as HAZWOPER. It is essential for personnel involved in developing decontamination procedures and selecting personal protective equipment for workers to be adequately trained. A wide array of chemical, biological, and radiological agents can lead to a decontamination event. While it is beneficial to be aware of common threats, particularly those identified in local hazard vulnerability analyses, a more critical principle is to understand general concepts and broadly applicable methods for decontamination. This knowledge enables a prompt initiation of decontamination efforts, even before the specific agent is identified. Once the agent is determined, procedures can then be refined accordingly. Occupational exposures to chemicals frequently involve airborne agents that are inhaled. However, dermal absorption may also occur for certain substances. The chapter on critically poisoned workers highlights various occupational toxicities. Many of these cases necessitate decontamination upon presentation to a healthcare facility, especially if external contamination has occurred or if the patient has been rescued from a contaminated environment. Examples include exposures that lead to occupational pulmonary toxicology, such as irritant inhalation, neurotoxic disorders related to carbon monoxide, hepatic injury, or renal disease. Instances involving exposure to simple asphyxiants or irritant gases can result in critical illness. In the context of decontamination in healthcare facilities, understanding the risk of secondary contamination is essential. This risk varies depending on the chemical involved, its concentration, and its physical state. Gases, vapors, and low-viscosity liquids tend to permeate more readily than high-viscosity liquids or solids, although substances that only cause inhalation exposure generally pose minimal risk of secondary contamination after the victim is removed from the source and their clothing is taken off. Chemicals with a high potential for secondary contamination require careful removal of clothing and thorough cleansing of the body. Certain agents, such as hydrofluoric acid, present particular challenges in management, including the risk of skin burns. Clinicians are often more familiar with biological agents, where decontamination is less likely to be a concern compared to infection control, which typically requires little more than a process of stripping and showering. Patients contaminated with radioactive material, as opposed to those who have merely been exposed to radiation, may also initiate decontamination using general measures. Decontamination procedures at a healthcare facility are designed to manage contaminated individuals in an efficient and safe manner. The aim is to protect both the staff and the facility while ensuring the health of the victims. This process is influenced by 4 primary factors: contact time, concentration, temperature, and the physical state of the contaminant. It is essential to consider these factors to effectively counteract their potential impacts. The first key step in the decontamination process is crowd control. Individuals who may be contaminated should be guided through a controlled corridor leading to the designated decontamination area. This helps maintain order and minimizes the risk of further contamination. Next is the triage process, which is vital for assessing the situation. It involves identifying the contaminant if possible, understanding the degree of contamination, and evaluating the level of distress experienced by the victim. Toxidromes, which are clusters of signs and symptoms, can assist in recognizing the class of agent when the specific chemical is unknown. Triaging personnel are responsible for determining who requires decontamination, assessing the potential for secondary contamination, and assigning appropriate protocols for each case. It is crucial that contaminated individuals do not enter the hospital until they have been decontaminated. Effective communication with the incident commander is necessary to ensure a coordinated response. Utilizing available resources for identifying the agent, such as emergency placards, material safety data sheets, or emergency support lines, is also important. If clinically indicated, and if resources allow, emergency resuscitation may take place in the decontamination area. However, routine diagnostic procedures should be delayed until the victim is moved to a safe area outside of the decontamination zone. The removal of contaminated garments is a crucial first step in decontamination, as this process can eliminate between 70 to 85% of harmful contaminants. All removed clothing, along with any jewelry, should be carefully double-bagged and preserved. These items may be necessary as evidence in criminal investigations, so it is essential to manage them in accordance with established procedures. Next, cleaning the contaminants from the body is vital. The most common and often safest method is to use a high volume of tepid water for dilution. If the individual has oily or greasy skin, mild soaps or shampoos may be required. Encouraging self-decontamination by the victim significantly reduces the need for staffing assistance during this process. It is important to avoid abrasive cleaning techniques since they can increase the absorption of contaminants into the skin. In cases of eye exposure, it is crucial to irrigate the eyes with plain water or normal saline. This irrigation should continue until symptoms improve or the pH levels normalize, particularly if an acid or base has been involved in the exposure. Additionally, if contact lenses are present, they should be removed promptly. Management of contaminated materials and equipment is critical in ensuring safety during hazardous events. Any item that has been used in the decontamination area, as well as vehicles used to transport contaminated victims, must be considered contaminated until they have been thoroughly cleaned. In emergencies where lives are at risk, runoff water from decontamination should ideally be collected. However, rapid flushing should not be delayed due to environmental concerns. The priority in such hazardous materials incidents is the protection of health over environmental considerations. A key principle for healthcare providers receiving patients after field decontamination is the understanding that basic victim decontamination, which involves stripping and flushing, significantly reduces or eliminates the risk of secondary contamination for medical personnel in the support area. Once a victim has been decontaminated, the use of sophisticated protective gear for general medical assessment and treatment in the support area is generally unnecessary. In most cases, simple surgical gloves, aprons, or disposable outer clothing will suffice. Effective healthcare facility-based decontamination requires prior training and planning. Key principles of preparedness include a comprehensive risk review, victim receipt and management planning, designated decontamination areas, staffing and training, resource management, and coordination with local agencies. A risk review is essential for informed planning and material selection. It involves assessing the hazardous agents known to be used by the facility and those present in the community. This assessment ensures that appropriate measures are taken to mitigate potential risks. The victim receipt and management plan is crucial to managing the entry of contaminated victims. This plan should establish a controlled corridor to prevent the spread of contamination. It must account for both anticipated and unanticipated arrivals to ensure an effective response to decontamination needs. Healthcare facilities should also prepare designated decontamination areas. These areas may include fixed units, mobile trailers, tents, or constructed facilities. They should be located to facilitate controlled access and minimize the risk of contaminant spread. Additionally, ventilation in the internal decontamination areas must be separate from the central facilities system. It is also necessary to plan for overflow areas to accommodate mass casualty events that exceed the capacity of the primary area. Dedicated decontamination teams are essential, and staff must undergo thorough training. This training should cover the visual identification of contaminants, the operation of monitoring equipment, the technical assessment of decontamination effectiveness, and the safe use of personal protective equipment. Ongoing monitoring is vital during decontamination procedures to ensure staff safety. Effective resource management is another critical aspect of this process. Facilities need to have all the necessary materials for decontamination, such as water, soap, and any potential additives. Additionally, managing waste is an important part of resource management. Lastly, coordination with local community response agencies is necessary. This includes communication with hazmat teams, police, fire departments, and regional poison control centers. Consulting a regional poison control center is advisable for obtaining specific guidance on decontamination procedures. In summary, healthcare facility-based decontamination is an essential component of emergency preparedness, particularly from an occupational health perspective. It requires a thorough understanding of the risks associated with various contaminants, adherence to regulatory training requirements for staff, implementation of structured decontamination procedures, and comprehensive planning and coordination with community partners. The ultimate goal is to provide critical care to patients with contaminated wounds while ensuring the safety of the healthcare workforce. Occupationally related medical problems, including exposure to chemicals, are frequently encountered in clinical practice. Musculoskeletal complaints are common. However, approximately 5% of consultations at poison control centers are related to occupational issues. This indicates that a significant number of work-related chemical exposures occur. Obtaining a thorough history of one's occupation is of utmost importance. This history should include a description of the job process and the equipment used, such as power tools that may pose a risk for carbon monoxide exposure. It is also vital to determine whether the work environment employs closed or open systems and to consider any nearby processes or workstations. Without a comprehensive occupational history, there is a risk of missing an occupational cause, leading to the suspicion of a different non-occupational etiology. For workers who are critically ill or deceased due to exposure in their occupations, the primary means of exposure for nearly all significant illnesses and injuries is through the air, specifically via inhalation. In certain cases, however, some chemicals have a designation indicating that systemic effects or toxicity can occur through absorption via the skin. A vital principle in managing cases of occupational exposure is that every poisoned worker should be regarded as a unique case. This implies that the clinician must conduct a thorough investigation to determine whether other workers in the same environment have experienced similar exposures and are also at risk. Furthermore, each case should prompt immediate actions aimed at preventing further incidents associated with that particular workplace or those specific chemical processes. Many countries have specific reporting requirements that require healthcare professionals to inform relevant government agencies when they become aware of workplace injuries. Hospitals are also concerned about regulatory compliance regarding the decontamination process, which is overseen by organizations such as the Joint Commission and the Occupational Safety and Health Administration. The Joint Commission mandates that hospitals have an emergency management plan that includes facilities for isolation and decontamination. The Occupational Safety and Health Administration requires that medical personnel involved in decontamination processes receive training to the first responder operations level. This training places particular emphasis on personal protective equipment and decontamination procedures. The training must include a minimum of 8 hours of instruction or demonstration of competency, along with an annual refresher course. Additionally, the Occupational Safety and Health Administration mandates that employers ensure a safe working environment, which encompasses decontamination procedures for victims to maintain the health of employees. Laboratory testing plays a limited yet vital role. While specific toxin testing is available, general testing to assess chronic exposure should focus on potential organ toxicity. Standard guidelines typically include a complete blood count, electrolyte assessments, tests for renal and liver function, as well as periodic chest radiographs and pulmonary function tests. Early spirometric evaluation is often crucial for significant inhalant irritant exposures. In occupational toxicology, the primary treatment strategy is to eliminate or reduce further exposure to the toxin, which includes safeguarding coworkers from exposure, modifying the workplace, and controlling hazards, especially by substituting less hazardous materials, should be the main preventative approach, ideally prioritized over personal protective equipment for workers. Medical management of occupational toxic illness adheres to established toxicologic practices. The administration of specific antidotes must be done with guidance from a regional poison control center or specialists, especially before starting chelation therapy for heavy metal toxicity. For severe cases of acute carbon monoxide poisoning, hyperbaric oxygen therapy is advised, particularly when there are end-organ effects, although the protocols regarding patient selection, dosing, and frequency may differ. Classic management of rhabdomyolysis involves ensuring adequate urine output and alkalinization. However, the clinical evidence supporting these specific methods is limited, mainly derived from small-scale studies. Conditions like renal failure following exposure to arsine or stibine may require exchange transfusions and dialysis. Healthcare providers must understand these occupational hazards and the evaluation and management principles to effectively address both acute chemical incidents and the more common, subtle manifestations of work-related illnesses. Occupational exposures can affect various organ systems and present as specific syndromes. One prominent example is acute irritant inhalation injury, which typically results from brief, intense exposure to harmful substances. The onset of symptoms can occur within minutes or may be delayed for up to 24 to 48 hours. The responses to these exposures can vary in severity, and may include irritation of the mucous membranes, burning eyes, a runny nose, tracheobronchitis, hoarseness, coughing, laryngospasm, bronchospasm, pulmonary edema, and ultimately acute respiratory distress syndrome. Substances like nitrogen dioxide, ozone, and phosgene, which have lower water solubility, may cause less irritation in the upper airway. However, they can still lead to pulmonary edema and acute respiratory distress syndrome after prolonged exposure. Inhalation of water-repellent fluoropolymer aerosols presents symptoms similar to those caused by low-solubility gas injuries. Nitrogen dioxide exposure often occurs during arc welding in confined spaces or when working with fresh silage in silos. This exposure can lead to delayed pulmonary injury and acute respiratory distress syndrome. Additionally, phosgene exposure is a risk during torch cutting or welding of metals that have been degreased with chlorinated hydrocarbon solvents. Furthermore, soluble gases such as hydrochloric acid, hydrofluoric acid, sulfuric acid, nitric acid, and ammonia are also irritants. These gases are commonly encountered by workers in acid and alkali production, as well as by those working in manure pits. Similar to other irritant gases, exposure to these substances can also result in acute respiratory distress syndrome. Simple asphyxiants such as carbon dioxide or inert gases cause toxicity by displacing oxygen in the air we breathe. This displacement leads to a condition known as anoxia, which is particularly dangerous in confined spaces. On the other hand, systemic asphyxiants like carbon monoxide, hydrogen cyanide, and hydrogen sulfide present different mechanisms of toxicity. Carbon monoxide, along with agents that induce methemoglobinemia, interferes with the loading and unloading of oxygen onto hemoglobin. Hydrogen cyanide and hydrogen sulfide bind specifically to the ferric part of the cytochrome A3 oxidase complex, disrupting cellular respiration. Hydrogen sulfide is notably relevant in contexts such as sewage treatment and oil and gas extraction. Carbon monoxide primarily originates as a byproduct of combustion processes commonly encountered by workers in garages, firefighters, and individuals who use paint strippers due to the metabolism of methylene chloride. The current workplace standard for ambient carbon monoxide exposure is set at 35 parts per million averaged over an 8-hour period, with a ceiling limit of 200 parts per million. It is significant to note that just 4 hours at a concentration of 100 parts per million can elevate carboxyhemoglobin levels to greater than 10%, presenting various symptoms. Unfortunately, the ability to detect agents like hydrogen sulfide by odor is not reliable for diagnosis. Inhalational fevers can result from inhaling both organic and inorganic materials, often manifesting as self-limited illnesses that resemble the flu. A classic manifestation of this is metal fume fever, which occurs after the welding of galvanized metal, producing fumes of zinc oxide or other metals such as cadmium. Polymer fume fever presents a similar syndrome that arises from inhaling the pyrolysis products of fluorinated polymers such as Teflon. Symptoms typically appear hours after exposure and resemble flu-like symptoms, but these syndromes generally resolve within a day without long-term effects. However, in cases of massive exposure, direct pulmonary toxicity may occur. Furthermore, organic dust toxic syndrome refers to inhalational fevers caused by organic dust mixtures within agricultural industries, which may include elements like bacteria, fungi, and grains. Symptoms usually present within hours and typically resolve without long-term effects. It is important to note that organic dust toxic syndrome is a diagnosis of exclusion, meaning that it is diagnosed after ruling out other conditions like hypersensitivity pneumonitis. Occupational respiratory diseases are relatively common and encompass two main categories: asthma that is caused by exposure in the workplace and asthma that existed prior to employment but is aggravated by work conditions. The first category is known as occupational asthma, while the second is termed work-exacerbated asthma. Occupational asthma can further be classified into two types: sensitizer-induced asthma and irritant-induced asthma. The sensitizer-induced form typically requires a latency period for sensitization, which means that symptoms may not appear immediately. Once an individual is sensitized, even minute exposures can lead to significant symptoms. Sensitizers can be categorized by the size of their molecules. High molecular weight organic compounds, such as animal dander and plant proteins, are complete allergens, while low molecular weight compounds, known as haptens, can also trigger reactions. Common sensitizers associated with sensitizer-induced asthma include isocyanates, with toluene disocyanate being a notable example, as well as metals such as nickel sulfate, acrylates, glutaraldehyde, and wood dust. Irritant-induced asthma, also known as reactive airways dysfunction syndrome, occurs following acute and high-level inhalations of irritants such as chlorine gas. This form of asthma may lead to chronic respiratory issues. Symptoms of occupational asthma can present themselves in a biphasic or dual manner, involving immediate and delayed responses, or may appear solely as delayed responses. The latter scenario can complicate the identification of the work-related link. The management of acute exacerbations of asthma follows a path similar to conventional asthma treatment. However, long-term management requires the identification and removal of the sensitizer to prevent further exposure. Chronic fibrotic lung diseases develop after extended periods of exposure and typically feature long latency periods. Although patients may present symptoms acutely, examples of these diseases include asbestosis, silicosis, coal workers' pneumoconiosis, and diseases resulting from exposure to beryllium, hard metals such as cobalt tungsten carbide, indium tin oxide, and synthetic textile fibers, which may affect workers in the flocking industry. It is advisable that individuals who are affected are referred for follow-up surveillance. Hypersensitivity pneumonitis, also known as allergic alveolitis, generally results from chronic exposure to organic materials like thermophilic bacteria and bird antigens, as well as certain chemicals, including isocyanates. Well-known examples of this condition include farmer's lung, caused by moldy hay, and bird fancier's lung, consequently from exposure to bird droppings. In sensitized individuals, hypersensitivity pneumonitis can manifest acutely after significant exposure. Other lung disorders can also arise, such as bronchiolitis obliterans, where exposure to diacetyl is a concern, commonly referred to as microwave popcorn worker's lung or nitrogen dioxide, which leads to a condition known as silofiller's lung. Additionally, bronchiectasis can occur following severe inhalation injuries caused by irritants. Certain occupational exposures are linked to cardiovascular effects. For instance, carbon disulfide is traditionally associated with accelerated atherosclerotic disease, particularly among workers exposed to high levels. However, the precise mechanisms behind this association remain unclear. Chronic exposure to carbon monoxide is thought to hasten the development of atherosclerosis, while acute high-level exposure can lead to severe complications such as myocardial infarction, vasospasm, and sudden death. Workplace toxins often impact the liver due to its role in metabolizing foreign substances. Occupational exposures may result in various liver conditions, including steatosis, cholestatic injury, hepatoportal sclerosis, and hepatic porphyria. Specific compounds that can induce liver damage include halogenated hydrocarbons such as carbon tetrachloride, as well as solvents like 2-nitropropane, dimethylformamide, and dimethylacetamide, which have the potential to cause hepatic failure. Therefore, a toxic chemical origin should always be considered in the differential diagnosis of liver disease. Numerous hepatotoxic industrial compounds also have detrimental effects on the kidneys. Acute tubular necrosis can arise from significant exposures to various toxins, though ingestion during suicide attempts is a more frequent occurrence than inhalation at work. Carbon tetrachloride stands out as a notable example that can lead to renal failure, often resulting from volume depletion caused by hepatotoxic effects, but it may also exhibit direct nephrotoxic properties. Toluene and several halogenated compounds, including chloroform, ethylene dichloride, trichloroethylene, TCE, tetrachloroethane, and vinylidene chloride, along with diesel fuel and ethylene chlorohydrin, are associated with acute renal failure. Additionally, myoglobinuric renal failure can occur due to substances that induce rhabdomyolysis. Interstitial nephritis can be linked to chronic exposure to heavy metals, while hydrocarbon exposure is related to glomerular nephritis. Chronic renal disease can be caused by arsenic, cadmium, and lead. Acute renal failure from arsine and stibine gases may result from hemoglobinuria due to massive hemolysis and cadmium exposure, particularly among welders working with cadmium-coated materials, is also related to acute renal failure. Neurotoxic disorders. This field is highly pertinent to occupational toxicology. Certain occupational toxicants can trigger CNS stimulation and seizures, such as organochlorine insecticides, e.g. DDT, cyclodienes, lindane. The bone marrow is targeted by substances like benzene and methylchelosol, which can induce pancytopenia. Hematologic toxicity. Industrial oxidants are a major factor in chemically induced methemoglobinemia, especially in the dyestuff and munitions sectors. This condition hampers the loading and unloading of oxygen by hemoglobin. As previously mentioned, chemicals like benzene and methylchelosol also affect the bone marrow, leading to pancytopenia. The most frequent toxin-related skin issues include allergic and irritant contact dermatitis, urticaria, and acute injuries from caustic chemicals or acids. Systemic toxicity is generally not a prevalent complication. Burns from hydrofluoric acid pose unique management challenges and are significant in fields such as microelectronics and maintenance involving rust removers. Musculoskeletal conditions. Although this group represents the most common occupational issues, they seldom have direct toxicological implications. Rare connections exist, such as Raynaud's syndrome associated with vinyl chloride monomer exposure or severe tissue necrosis resulting from high-pressure injection injuries, e.g. from paint spray guns, where local tissue damage takes precedence over systemic toxicity. Adverse reproductive outcomes. These have been linked to occupational exposure to heavy metals like lead and organic mercury, exposure to chemicals in hospitals such as anesthetics and sterilizing gases, and the use of banned fumigants like dibromochloropropane. Work-related psychological disorders. These encompass a range of diagnoses including PTSD and mass psychogenic illness. Patients may perceive their symptoms as stemming from chemical exposure. Psychological diagnoses should be considered when nonspecific symptoms or multiple somatic complaints show no objective findings or physiological connections after excluding reasonable toxicological causes. This discussion will include insights from the case study 13 scenario and the extensive overview found in the critically poisoned worker, along with pertinent supporting information from other sources. This case study describes a crucial situation involving a 29-year-old bank teller who was discovered unresponsive and without a pulse in a bank vault after the door closed behind her. She activated the fire alarm when she was unable to receive help. Emergency responders arrived to find her in cardiopulmonary arrest with chest compressions already in progress. There were no visible signs of trauma. The main principle emphasized by this case study is the necessity for immediate suspicion of environmental or chemical exposure in a confined space when sudden collapse or cardiopulmonary arrest occurs. The absence of trauma coupled with the environment, a closed vault, strongly indicates that her severe condition stems from something she inhaled or was exposed to in that restricted space. Sources specifically identify confined spaces such as reactor vessels, tanks, silos, or pits as high-risk areas where hazardous gases can gather or displace oxygen, leading to swift incapacitation and potential death. Simple asphyxiants, including heavier-than-air gases like carbon dioxide, can accumulate in lower areas, increasing the risk for a victim who collapses on the floor. The specific exposure detailed in the case study is not explicitly identified in the provided excerpts. However, the scenario of collapse in an enclosed space after a potential fire alarm suggests possible smoke involvement, even though the text does not explicitly mention fire. This situation raises concerns about critical airborne toxins. Carbon monoxide and cyanide are particularly relevant in this context. Carbon monoxide is a standard toxic product of incomplete combustion. It has been specifically noted as a cause of ischemia and acts as a neurotoxin that can lead to ischemic injury to the basal ganglia following severe poisoning. Additionally, cyanide exposure is also associated with smoke inhalation. Both carbon monoxide and cyanide can cause rapid effects on the central nervous system, leading to collapse and cardiac arrest. Hydrogen sulfide, another gas that can accumulate in confined spaces such as manure pits, is notorious for inducing rapid impairment and sudden cardiac arrest at high concentrations. The principle derived from this information is that for a patient presenting in critical condition who has been in a confined space, immediate consideration must be given to the possibility of toxic gas exposure or oxygen deficiency. This necessitates the prompt removal of the patient from the environment by appropriately protected rescuers. Furthermore, supportive care must be initiated, including ventilation and potentially the empirical administration of antidotes if exposure to agents such as cyanide or hydrogen sulfide is suspected based on clues from the scene or clinical signs. Here are the key points regarding occupational exposures from the perspectives of emergency medicine and toxicology, drawn from the provided content. Occupational medical problems, including exposure to chemicals, are common within clinical practice and account for a significant portion of consultations at poison control centers. Recognizing these issues is essential for effective patient care and prevention. Local emergency response providers, such as hazardous materials hazmat teams, are specially trained to respond to chemical incidents. It is important for healthcare providers to engage in planning sessions and drills alongside these teams to ensure preparedness. For first responders, the ability to recognize hazardous situations and ensure their own protection is fundamental. This includes evaluating the scene and understanding the chemical properties involved, such as their warning properties and vapor pressure. A significant concern is the potential for secondary contamination of personnel and facilities. Although not all toxins carry this risk, proper decontamination procedures are vital in reducing the likelihood of contamination. Airborne exposure through inhalation is the primary pathway for significant occupational illnesses and injuries. However, some chemicals may also cause systemic effects through skin absorption, which is referred to as skin designation. Taking a thorough occupational history is crucial. Missing this information can result in misdiagnosis and inadequate treatment. Every worker who is poisoned should be treated as an index case, emphasizing the need for an investigation into other potentially exposed workers and implementing prevention strategies for future incidents. Healthcare facilities must be adequately prepared to manage contaminated patients who present directly to the hospital. This preparedness is vital to ensure the safety of both patients and healthcare providers. Decontamination within healthcare facilities is essential for several reasons. It helps prevent further absorption of harmful substances by victims, reduces the risk of secondary contamination to other individuals and equipment, and prevents the potential closure of the facility. Regulatory bodies, such as the Joint Commission and the Occupational Safety and Health Administration, require hospitals to have emergency management plans that include decontamination facilities. Medical personnel involved in decontamination operations must be trained to at least the first responder operations level. This training emphasizes personal protective equipment and the procedures necessary for safe decontamination. Healthcare workers stationed in these areas are considered occupational responders and therefore require specific training and protective measures. Occupational exposures during decontamination can lead to a range of toxic syndromes that affect multiple organ systems. These complications can include acute irritant inhalation injuries, asphyxiation, inhalational fevers, occupational asthma, chronic lung diseases, cardiovascular effects, and various disorders affecting the liver, kidneys, and nervous system. Additionally, skin problems, musculoskeletal conditions, reproductive issues, and psychological disorders can also arise from such exposures. The cornerstone of effective management during these scenarios is to eliminate or reduce any further exposure to harmful substances. Medical treatment typically follows established toxicological principles and often necessitates consultation with a poison control center or specialist to obtain specific antidotes. In the event of sudden collapse or cardiopulmonary arrest in a confined space, there should be immediate concern for potential environmental or chemical exposure. This is particularly true for scenarios involving oxygen deficiency or toxic gases such as carbon monoxide, cyanide, or hydrogen sulfide. It is critical to ensure prompt removal from danger and to provide supportive care for affected individuals. Basic victim decontamination primarily involves stripping away contaminated clothing and flushing the body with water. This initial response can significantly reduce or eliminate the risk of secondary contamination for medical personnel operating in support areas. Effective healthcare facility-based decontamination demands thorough prior training, detailed planning, designated areas for decontamination, well-trained staff, efficient resource management, and strong coordination with community agencies.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.